Morning, everyone. Thank you for joining. We'll get started in another 2 minutes. Good morning, everyone. We'll get started in another minute. Okay, everyone, good morning. My name is Perun Katari. I'm today's Aspire host for Dr. Carcamo Cavazos, who's an assistant professor in the UCLA Department of Anesthesiology and Pain Medicine. She's fellowship trained in regional anesthesia and acute pain medicine and is a member of the Acute Pain and Regional Service at the Ronald Reagan Medical Center at UCLA. In addition, she serves as the Associate Program Director of the Regional Anesthesia and Acute Pain Medicine Fellowship at UCLA, where she is responsible for the fellows rotation while at the main medical center. Dr. Carcamo Cavazos has a strong interest in the treatment of acute pain and perioperative patients to improve their patient care and outcomes. She's published an article as a first author in Advances of Anesthesia in 2022, titled Opioid for Anesthesia, The Pros and Cons. She's also presented at numerous grand rounds at UCLA on various topics relating to acute pain and regional anesthesia. She's also has multiple case presentations at the American Society of Regional Anesthesia meeting and is an active member of the society. Dr. Carcamo Cavazos, thank you so much for your time this morning. We look forward to your talk. For the audience, remember, please use the Q&A feature for a discussion at the end. And Michelle will be using the usual features for attendance and CME as well. Thank you, and take it away.
Thank you so much, Dr. Kutari, for that introduction. So the title of my presentation today is Perioperative Pain, a complex experience that requires comprehensive assessment and management. The objectives of my presentation are first to describe pain and the multiple determinants of perioperative pain that make it a complex experience. I want to also convince you, the audience, of the essential role that all anesthesiologists play in the perioperative pain management to improve patient care and surgical outcomes. And I want to provide a set of tools to help you, the audience, predict postoperative pain and develop an evidence-based approach to postoperative pain management for patients in the perioperative period. Here's the outline of my presentation. First off, why does acute post-surgical pain management matter for the average anesthesiologist? The low bar for anesthesiologists is to keep patients alive in the perioperative period. Of course, this is the main goal if we have a very sick patient with many comorbidities, or if we get a trauma patient that's bleeding significantly, our main goal will be to keep them alive. But for most of us anesthesiologists, we have much higher standards for our anesthetic care. We want to make sure the patient gets the best surgery possible, that they have a good postoperative recovery, and we want to ensure that they maintain optimal health in the short and long term. And there's many ways we do this. We optimize surgical conditions by, for instance, lowering the blood pressure as fast as it's safe to create a bloodless feel, or we position the patient in such a way that the surgeon can have the best surgical approach to do their surgery. We give antibiotic prophylaxis appropriately, so we minimize or diminish the risk of surgical infections that can really affect patients' recovery. Another way in which we anesthesiologists are particularly positioned to improve surgical outcomes is by providing appropriate acute postoperative pain management, because that aids in patients' recovery after surgery, and also it prevents the development of chronic post-surgical pain and also opioid addiction, both conditions which can be very detrimental for the patient's long-term health. What is pain? The updated definition of pain by the International Association for the Study of Pain in 2020 is an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. As most of us know, pain is not only a sensory experience, but it also has a very important and real emotional component. And it doesn't always have to have a tissue injury. It has to at least resemble tissue injury. So pain is subjective. It is unique to each person. It is real. It is not equal to nociception. And it can be both adaptive and maladaptive. Pain in general is complex. Therefore, a multifaceted and individualized approach to its management is essential for every patient. And the goal of periop pain management is to ultimately improve surgical outcomes and the patient experience. One essential way to treat pain is to create a perioperative pain management plan for each individual patient. So we should understand the characteristics and determinants of acute post-surgical pain. Let's first talk a little bit about a kind of pain, acute pain. Acute pain, we think, is mostly an adaptive. It serves an adaptive role. It helps us protect our body from harm. Thus, the best way to treat acute pain is to remove the insult causing the pain. So, for instance, if you step on a sharp object, the way you're going to treat that pain is not going to be by taking some oxycodone if you had it. It'd be by removing your foot from the sharp object. Now, acute post-surgical pain is unique in that acute post-surgical pain is a consequence of surgery, a symptom or side effect of surgery. And surgery is a necessary or at least a desired procedure where there's controlled tissue injury for a specific purpose. So the insult that caused the pain has been removed once the patient actually experiences the pain in recovery. So in this case, we do need to treat the symptom of pain. Therefore, acute pain after surgery is normal. Our goal is to make it as tolerable as possible to decrease suffering and improve recovery through functional goals, while minimizing side effects from pharmacologic and non-pharmacologic pain management intervention. And it is important that we understand this about post-surgical pain, that it will exist, and that we educate patients starting in the perioperative period about the existence of acute post-surgical pain and normalize it. Acute pain is part of surgery, but we'll make it as tolerable as possible. Acute post-surgical pain can be inferred based on the surgical procedure and patient characteristics. Unfortunately, acute post-surgical pain cannot be precisely determined. We can only make our best educated prediction, and then we adapt our plan depending on patient's actual pain trajectory after surgery. Let's talk about surgical factors that affect post-surgical pain. Some basic trends that most of us are familiar with. The more invasive and expensive surgeries tend to lead to more pain, whereas minimally invasive surgeries in small areas are minimally painful. Pain, however, varies widely, even when patients undergo the same surgery. And I see this every time I'm in the acute pain service where two identical patients getting seemingly identical surgeries have very different pain trajectories after their surgery, even with very similar treatment modalities. Now we have limited data in terms of what is the expected pain after every single surgery. There was a group in Germany by Gerber-Schagen who tried to determine pain intensity on the first day after surgery. It was a prospective cohort study comparing 179 surgical procedures. Basically, they collected data from 115,000 surgical patients on 578 surgical wards on 105 German hospitals, of which only 70,000 patients were included in the analysis. And the authors collected pain scores using an NRS scale on post-operative 1, as well as they collected analgesic consumption after discharge. And their aim was to determine the pain intensity of a large number of surgeries on post-operative 1 after various surgical procedures with standard pain management practices. An important point to make about this study is that it looked at pain only during 1 day, post-operative 1. So it is a limited vision or limited view of post-operative pain in these patients after the surgeries, and also in the context of how pain is treated in Germany, which may or may not be similar to the way we treat patients in the US. And from their study, the authors came up with this chart that shows pain scores on the first post-operative day after the 179 surgical procedures. And I realized you can't read this chart because it's very long since there's so many procedures, so we'll zoom into the top of the chart. And this is what this chart looks like. They basically show, again, this is in the top of the chart, they put first the surgeries with the higher pain scores post-operative 1. And here they show the type of procedure, the average pain level with the variations in pain, as well as the median pain score and morphine equivalence in post-operative 1. And how you can use this table is that it can give you an idea of how painful a procedure may be. It is not absolute, of course, and it is not 100% applicable to patients in the US, but I think it can show you some trends. And really, this is one of the few papers that has this type of robust data. And in general, we do have limited data that tells us expected pain after surgery and what the pain trajectory will be. We largely rely on expert opinion for both surgeons and anesthesiologists, pain specialists, to know what a pain trajectory may be after surgery. And also in our own experience, if we are somebody who does the same type of procedure in a consistent basis. Now, to create evidence-based resources that can help the average anesthesiologist in their procedure-specific post-operative pain are the Michigan Open, or Overdose Prevention Engagement Network, and the Prospect Guidelines that I want to share with you. Michigan Open is an organization that aims to give evidence-based opioid prescribing recommendations for adults with the aim to recommend a dose of opioids that should still control postoperative pain appropriately, while at the same time minimizing the number of leftover opioids in the community, which can have a lot of adverse effects in the health of the community. And although not a perfect correlation, the number of analgesics needed after a surgery does kind of correlate somewhat with the amount of pain we expect after surgery. So I use this chart to help me know how painful a surgery is expected to be. For instance, they recommend a maximum of five pills of oxy to be given for breast biopsy or lumpectomy. I know this procedure is not very painful, and I also know that because of my own experience. And conversely, for the total hip, total knee arthroplasties, they may need a lot more opioids, so they're likely more painful. The Prospect Guidelines are guidelines developed by the European Society of Regional Anesthesia and Pain Medicine. They're also evidence-based guidelines on the best ways to control pain after surgery for specific procedures. And if you go onto their websites, you can also look at what the expected pain level is after specific surgeries. Now let's talk about patient factors that affect acute post-surgical pain. There's many studies looking at factors that may predict post-op pain. There's also a number of systematic reviews looking at this. And I don't have the time, and I don't want to overwhelm you with all the different studies, but this will be available in my citations as well as in my presentations that I believe will be shared with you. But I will just provide a number of, or a summary of the findings of these various papers. In terms of patient factors, we know that female sex has been associated with higher risk of significant pain of longer duration. In terms of age, younger patients have more pain and analgesic use, whereas older patients tend to have lower pain scores, but their pain can be sometimes more difficult to treat because they also have higher risk of side effects from opiates, respiratory depression, confusion, delirium, as well as they are at higher risk of side effects from non-opioid pain medications. Also, older patients tend to have more comorbidities, so that certain medications are contraindicated for them, and they have prescription medications that might interact with perioperative analgesics and other perioperative medications that they might need. Also, neuraxial techniques might be more difficult to perform in this patient population because of osteoporosis, osteophytes, and so on. Other important patient factors to consider are medical conditions. Chronic pain is a big one. It increases the risk of severe and prolonged postoperative pain, and it also increases the likelihood of difficult to control pain. Obesity has also been associated with poor postoperative pain control, and in addition, it's difficult to perform regional in these patients, whether it's nerve blocks or neuraxia, and they're also more prone to the adverse effects from sedating medications, of course, and importantly, opioids. Patients with obstructive sleep apnea are at the same risk of perioperative pain as a normal patient, but they are more prone to the side effects of sedatives, including opioids. Patients with renal failure have altered metabolism and clearance of medications, so we have to more cautiously choose which medications we administer to them and modify the doses based on the renal clearance of these medications. Also, there are increased risk of coagulopathy, which can be a contraindication to some regional techniques. And then coagulopathy, of course, is a possible contraindication to some regional techniques. Other important patient factors to consider are psychological conditions. Anxiety, depression, and smoking are all associated with worse postoperative pain, and substance use disorder makes it more difficult for us to treat pain in patients. Now, again, why is it important to predict postoperative pain based on surgical and patient factors? Because that will allow you to devise a perioperative pain management approach that is effective and safe for a particular patient that we can start implementing in the preoperative period. And I really want to emphasize this, that you might be the only person that will be able to start implementing an analgesic plan for this patient in the preoperative and intraoperative period. Because of this, I will focus my talk on these two instances of the periop period, because that is where you, the general anesthesiologist, can have the biggest impact in post-surgical pain management. Now, let's talk about management of acute post-surgical pain in the perioperative period. So acute perioperative pain management strategy for all procedures should be a multimodal opioid-sparing approach. And of course, the various components of this approach will vary depending on patient and surgical factors, as we discussed. But in general, this should be the main approach. Now, of course, perioperative pain management is much more complex than just the medications or analgesic techniques that we use. We should provide patient education. We should adjust our plan. And with this in mind, a number of experts in acute pain medicine convened to develop a set of guiding principles for the management of acute post-surgical pain, which they published in this special article in the Regional Anesthesia and Pain Medicine journal titled A Multi-Society Organizational Consensus Process to Define Guiding Principles for Acute Perioperative Pain Management. And these are the list of guiding principles for perioperative pain management, and I'll go through each of them. So the guiding principles call for us to conduct a preoperative evaluation, including assessment of medical and psychological conditions, concomitant medications, history of chronic pain, substance abuse disorder, and previous postoperative treatment regimens and responses to guide perioperative pain management plan. And this should be done for all patients, most times just in the preoperative area, and that will be your role as the intraop anesthesiologist. And most times it's a relatively simple task. Of course, if you get a chronic pain patient, then it might require a little bit more digging, but it is very important that you start performing this preoperatively. Of course, if the patient is very complex, hopefully they were seen by a pre-op clinic, but we know that this is not always the case. The second guiding principle states, use a validated pain assessment tool to track responses to postoperative pain treatments and adjust treatment plans accordingly. And this is something that likely I will use as an acute pain physician, mostly in the postoperative period, but it does become important when you have a chronic pain patient because you can use a validated pain assessment tool, the NRS scale, to help us determine what the baseline pain is for this patient and start adjusting expectations for these chronic pain patients. For our regular patients, we won't be using these NRS tools pre-op mostly. We will offer multimodal analgesia, as I already stated, for the treatment of postoperative pain in adults. We will also provide patient and family-centered, individually tailored education to the patient, including information on treatment options for managing postoperative pain, and document the plan and goals for postoperative pain management. Again, you might be the first person talking to the patient about their pain management options if that's something that's of their concern, or if we're considering a regional block or an epidural. I don't know how it is at other institutions, but at UCLA, as the pain management service, we often identify patients that we think would benefit from neuraxial or a nerve block, and the acute pain service might serve this role for specific patients. But say the acute pain service did not identify your patient, you might want to be the one offering the different options and get the pain service involved in pre-op. We also should provide education to all patients and primary caregivers on the pain treatment plan, including proper storage and disposal of opioids and tapering of analgesics after hospital discharge. And again, what you can do is educate the patients about your pain management plan, multimodal pain management plan, and especially for ambulatory patients, you might be the first and only person who educates patients about the benefits and risks of opioids. The second to last guiding principle asks for us to adjust the pain management plan based on adequacy of pain relief and presence of adverse events. And of course, this is something that most anesthesiologists won't be doing. It'll be the role of the surgeons and acute pain physicians. And last but not least, we should all have access to consultation with a pain specialist for patients who have inadequate pain control or who are at risk of poorly controlled pain after surgery. And thankfully, most large academic institutions have access to acute pain specialists that they can consult at any point during the peri-op period. And you should feel empowered to involve your acute pain physicians in pre-op or even intra-op if that's where you realize your patient might need advanced pain management help. Now, how do we come up with our perioperative pain management plan for any specific surgery? Many of our institutions have ERAS pathways, so we can definitely start there. There's also a great algorithm presented in UpToDate about how you can do a more individualized perioperative pain management plan for your patient. And I will just briefly go through this algorithm. Basically, we first always start with our perioperative evaluation to determine whether our patient is at high risk for significant pain after surgery or difficult to control pain after surgery. If that's the case, then we should have a more comprehensive assessment and management of their pain and involve multiple specialists. If that's not the case, then for all patients, we should do some basic techniques. We always say non-pharmacologic interventions should be part of the perioperative pain management. Compression, elevation, patient education is a big one, and it's really what you will be doing in pre-op mostly. Non-opioid analgesics that we should all be giving are Tylenol or acetaminophen and NSAIDs unless contraindicated. Local anesthetic wound infiltration is something that all surgeons should be doing. And of course, regional anesthesia techniques when indicated. And then you will also ask yourself, how painful will the procedure be? And we talked about how we can try to determine that. And based on that, you might say, okay, this is sufficient pain management because mild pain is well-controlled post-surgical pain. We don't need to do much else. If the pain is going to be moderate severe, you may want to add additional medications that do come with side effects, like gabapentinoids, consider ketamine or lidocaine infusion if available. And then you should add opioids as needed. One thing that I disagree with this chart about is that even for severe pain, I never schedule opioids. I always write them as needed. I am more likely to write for an dilated PCA for these patients who might have severe pain. But again, that will be the role of the surgeon or the acute pain service. Now, of course, acute pain management will depend on what techniques and medications are available at your hospital. So definitely consult your colleagues, the acute pain department, to see what's available. Another great resource to create a perioperative pain management plan is to, again, look at the prospect guidelines. And I like these guidelines because, unlike the ERAS guidelines, which you can look at also, not only from your institution, but the ones that are published online, is that these are specific to perioperative pain management, whereas the ERAS guidelines talk about many aspects of the perioperative period that can help us enhance recovery. And again, these guidelines are evidence-based guidelines. If you go to the Prospect website, you will see a number of procedures presented. You can choose the one that you're doing. So for instance, if we choose laparoscopic cholecystectomy, it will then show me the summary of recommendations. The Prospect recommendations also always tells you a little bit about Prospect. Then they tell you what the expected pain after this surgery will be, as well as some aims of this specific review. They give you a summary of the recommendations and the key evidence behind it. They also tell you recommendations that they interventions that they do not recommend. And then they'll give you a number of they'll give you the recommendations in a number of more digestible ways, including a chart as well as an infographic. And this is just an example of an infographic of the recommendations, which is really simple, really straightforward. This is a great resource. Now, it is important to emphasize an opiate-sparing approach. The reason is that opiates come with a lot of short and long-term side effects, and this is the part which we should be really educating our patients about. The short-term side effects of opiates we're all familiar with. They include nausea, sedation, constipation, respiratory depression, itching, urinary retention, overdose, and death. And long-term, there's the risk of tolerance, dependence, addiction, opioid-induced hyperalgesia, withdrawal, overdose, and death. Now, what's the right dose of opiates to order or prescribe? I always say the lowest effective dose that ensures tolerable pain while minimizing side effects of all pain management interventions, especially those of opiates. Of course, the lowest effective dose will depend on the surgery and on the patient, but that is just a general rule. Really, you should minimize opioids as much as possible. And the opioids should be the first medication that patients stop using for post-surgical pain control. In terms of prescription opiates, you can refer to Michigan opiate prescribing recommendations. And of course, most of us, even as a pain physician, we will not be writing opioid prescriptions. Now, we're all aware that there's an opioid abuse crisis in the US. And we should all know that prescription opiates can be the start of opiate addiction for many patients. And I just wanted to share a few stories from the CDC website to illustrate how prescription opioids can really affect lives.
We were driving to the supermarket, and as we entered the parking lot, a car ran a stop sign and completely T-boned us. When I was first prescribed my prescription pain meds, there was nobody to tell me that these have a really high potential for addiction. How could I be addicted? I get these from my doctor. It kills your soul and it makes you feel worthless.
My son, Christopher Parado, was 20 years old when he was prescribed opioids. It took him 5 days to get addicted. I'm not supposed to be the one to go get his suit and tie and pick which sneakers that I'm going to bury him in. My son overdosed at the age of 22 years old.
I was given a prescription opioid pain medication that lasted a lot longer than the pain itself. At the time, I didn't understand the dangers of these drugs, and within only a few months, I was completely addicted. I lost everything. I had to leave school and stop playing sports in college, and I started to watch my life slip away. These drugs are addictive. One prescription can be all it takes to lose everything.
So a common theme in these tragic stories is that patients seem to be somewhat unaware of the dangers of prescription opiates. They're like, oh, they're prescription medications, they must not be as dangerous. Also, opiates can be, patients can get addicted to opiates in a rather short amount of time. And in the last story, Mike, he was given a much larger prescription than the duration of the pain. And in general, anesthesiologists play an essential role in preventing opiate addiction with appropriate patient education on the benefits and risk of prescription opiates. And I do this a lot in the post-op period as an acute pain physician, but I do want to empower you to do this in pre-op because you might be the only person who will educate the patient on the benefits and risk of opioids in the perioperative period, especially in the ambulatory setting. So I will do some opioid patient education in my pre-op evaluation of patients in ambulatory settings for the most part. Now, acute post-surgical pain management should start in the perioperative period and for select patients in the perioperative clinic. And I know I've mentioned this before, but this is where you will come, where your role is very important. Again, we can look at our 7 guiding principles for perioperative pain management, and we can't apply them all, but we can apply many. We can start, we can again assess the patients to see to what extent they're at risk of severe pain after surgery. We can assess their baseline pain if they're chronic pain patients. We can start providing patient education on the multimodal pain management approach and the benefits and risks of opiates. And we can, of course, involve the acute pain service if we think our patient will benefit of their expertise. Now, a big technique of perioperative pain management that I keep emphasizing is multimodal analgesia. So I will give you a few tips of things that you should consider ordering for your patients. One is pre-op Tylenol and NSAIDs. should always be given unless contraindicated. Nowadays, we said that gabapentin should only be prescribed if patient is already taking it. When I was a resident, gabapentin was part of many of the ERAS pathways, but nowadays, based on the meta-analysis that I'll share in a moment, we no longer recommend that patients routinely get gabapentin in their post-surgical pain management plan. Also, you can start with psychological support and setting pain expectations. Education is very important in pain management. And reserved for patients that increase risk of severe pain due to surgical or patient factors, we have our regional techniques, neuraxial or peripheral nerve blocks. Now, why do I and many pain physicians emphasize the use of both Tylenol and NSAIDs together? There was a qualitative systematic review published in 2010 that showed that the combination of acetaminophen and NSAIDs is more effective at controlling pain than either medication alone. And they're both relatively safe medications with some caveats, of course, so they should always be prescribed and given starting in pre-op for perioperative pain management. Now, there was a large systematic review published in 2020 that studied the perioperative use of gabapentinus for the management of postoperative acute pain. And what the authors found was that gabapentinus were not associated with clinically meaningful different postoperative pain intensities. They did not decrease the development of chronic post-surgical pain, and they came with a number of adverse effects, dizziness and visual disturbances. So because of this, we no longer recommend gabapentinus be given routinely to surgical patients unless they have difficult to control pain or they're taking gabapentinus for pain management preoperatively. Now, let's talk about acute post-surgical pain management intraoperatively. And because intraop our patient is unconscious, there's many of the guiding principles of perioperative pain management that we cannot apply. But we can maybe still use a validated pain assessment tool. I'll talk about it more in a moment. And I always like to empower all my colleagues and all of you that if you found out that there's your patient is at risk of severe pain after surgery, intraop because the surgery was converted to open or because you got new information, please involve the pain service then, if that's the earliest you can. Now, before we delve into multimodal analgesia intraoperatively, I have a question for you. Do patients experience pain under general anesthesia? And the answer is no. Again, the definition of pain by the IASP is an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. So pain requires an emotional component that patients do not have while unconscious under general anesthesia, so there's no pain under general anesthesia. Patients experience nociception under general anesthesia. Now, how do we infer nociception? We use imperfect surrogates for nociception that we can measure using our standard monitors. Largely sympathetic system activation, tachycardia, and hypertension are some very common ones that all of us use. Also, increased respiratory rate can be used when the patient is paralyzed. There's also multiple commercially available nociception monitors that use one or more surrogates of nociception to infer nociception, mainly sympathetic system activation. I won't delve into the details here because it's beyond the scope of our practice, but those seem to be a little bit more objective measures of nociception, but they're not widely used. We certainly don't use them at UCLA. Now, should we treat all nociception under general anesthesia with opiates? Generally, we shouldn't. We should learn to think more critically about nociception intraoperatively as different entities depending on the cause of the nociception. Is the nociception due to endotracheal intubation? We know that happens in all procedures that get general anesthesia with an endotracheal intubation. Is it because of folate placement? Is it because of surgical incision? Is the nociception due to tourniquet pain, which goes away after the tourniquet is released? We should treat nociception with opiates only when it will linger into recovery to become acute post-surgical pain. Now, what type of multimodal can we offer intraoperatively? And again, I'm just going to give you a list of medications. Intraoperative Tylenol and NSAIDs should be given unless contraindicated or unless you administer them pre-op. Now, if the surgery is long enough, you can redose them intra after 6 or 8 hours have passed. Local infiltration analgesia should always be administered by the surgeons, and surgeons, I think, are generally pretty good about this. Dexamethasone also contributes to pain management. And you should start dosing opiates according to the expected level of surgical pain postoperatively, ideally at the end of surgery. Do not dose opiate based on the pain at during surgical incision, because that's a much higher level of pain. So you might end up overdosing the patient. Or also reserved for patients an increased risk for moderate severe pain due to surgical or patient factors. You can add a few other medications or techniques, which I've mentioned earlier. Again, regional anesthesia. This should have been placed preoperatively, but you can start your epidural intra-op as soon as you feel comfortable doing so. And the regional block catheters, they're mostly in place once they've been done pre-op, since we dose regional blocks for pain intra-op and post-op. You can also add ketamine and lidocaine infusions. And dexmedetomidine bolsters or infusions can be given for patients who are at risk of significant pain after surgery and also at risk of emergence delirium. Now, I will quickly go over acute post-surgical pain management in the post-op period and beyond, because the reality is that most anesthesiologists will not have a role in this part of the post-op of the periop period. And just general, this is where surgeons and acute pain physicians can really apply the guiding principles for perioperative pain management and do shared decision-making, do a lot of education, adjust the plan depending on how patients respond to different analgesic techniques. But most anesthesiologists won't have a role here. So in conclusion, pain is a complex and multifaceted experience that requires comprehensive assessment and management. Appropriate acute perioperative pain management is essential to improve surgical outcomes and patient satisfaction and long-term well-being. And very importantly, all anesthesiologists play a crucial role in safe and effective perioperative pain management. And I'll take any questions you may have, and thank you so much for joining me this early Monday morning.
Thank you so much, Dr. Carcamo Cavazos. Really appreciate your time this morning and your overview and your approach to the perioperative pain management of your patients. We have a couple of questions in the Q&A lined up. I'll just start as they've come in. As we reduce opioids, what common patterns have you seen in culture or sex bias under treatment or over treatment, and specifically in those populations? Can you provide some practical advice in avoiding a biased treatment of these patients?
Can you repeat the middle portion of
Sure.
the question?
As we reduced opioids, are you seeing some patterns in the way we treat certain cultures or certain sexes based perhaps under treating them or over treating them? Can you provide some advice on how you approach that problem?
Yeah, I think the factors that I described that increase the risk of severe pain management are just help us devise an initial periop pain management plan. And the big thing is that you should always adjust your plan based on how the patient responds to the plan. And I think we can sometimes be biased to say, like, oh, this chronic pain patient, just as an example, always says they're in 8 out of 10 pain, so I will not give them more opioids. But really, in these patients, they're very challenging to treat. And my approach is to look at function in these patients. I'll listen to their pain. I never dismiss somebody's description of pain. They tell me their pain, that it is real. I just try to understand where that pain is come from. And I try to balance treating their pain while also keeping them safe by not giving them excessive amount of opioids, giving them unrealistic expectations about what analgesic management or what analgesics they can be provided for their pain. If I were to give too many opioids in the perioperative period to patients, they will not find anybody who will prescribe those opioids as it should be. I don't trying to think of, and this is just coming as, this is from the perspective of an acute pain physician that deals with many different kinds of patients in the post-op period. I don't feel I try to not feel biased if, say I have a patient with substance use disorders. I definitely don't give them too many opioids, but I still listen to their pain. I do definitely use function largely to assess how well they're doing, and then use their pain scores more as a trend rather than as an absolute value. There's patients who will always say they have 10 out of 10 pain.
Thank you very much.
Yeah.
Our next question is from Dr. McKenzie. Do you see a role for THC or CBD or other synthetic analogs like nabilone and dronabinol in the treatment of multimodal pain management?
So we at UCLA we do use dronabinol, and we use it in the context of patients who use marijuana at home. We use marijuana daily at home, and we do find anecdotally that it helps. But so far, there's been a number of studies done on the benefits of THC and cannabinoids for acute pain management. And unfortunately, in spite of all the anecdotal benefits of cannabinoids for pain management, the data doesn't show benefit, which is a little disappointing. But I will not give dronabinol if the patient is not using marijuana at home. But I do find that it's helpful if the patient uses marijuana daily at home. So currently, just for most patients, we will not be prescribing cannabinoids for post-op pain management because the evidence does not support their use.
Thank you. Dr. Jean-Louis Horn, who you probably know is our outgoing chair of regional anesthesia division here, asking about any recommendations to use methadone as the intraoperative main opioid.
I think definitely methadone can be a great medication to use in patients who are opioid tolerant, who are getting very painful surgeries. We do use it at UCLA in specific patients, but it also should be used with caution because it can lead to respiratory depression in PACU. But yeah, absolutely. And there's a lot of information, there's a lot of data behind it. There's a lot of benefits about more stable pain control with the use of methadone. In general, in my experience, we use it for big spine surgeries, or if say we have a patient getting a big open abdominal case where they can get neuraxial. We've had an instance when a patient got methadone from a provider that does not provide or does anesthesia at UCLA as often. And we also did an epidural for that patient. And the patient had hypercarbonic respiratory failure in PACU, and we had to give naloxone to that patient. So, but yes, methadone is a great resource. And, I think there's great resources online like UpToDate and others where you can find out more specifics of how to effectively use methadone. It is not something that I use often, but it's something that we do use every once every few weeks.
Thank you. The next question is regarding preoperative anxiety. If preop anxiety is a risk factor for postoperative pain, how should we best address this anxiety? Can you suggest any non-pharmacological interventions that work well and that can be implemented quickly at the bedside, given that we always are in a rush to bring the patient back and start the next case?
Patient education can be a really valuable tool. I think taking the time to answer your patient's questions, I do recognize that we're all in a rush. We often have less than 30 minutes or 10 minutes to assess the patient. But sometimes we need to choose the patients in whom we should spend more time reassuring them, educating them. And here you can start adjusting patient expectations. And I think we all have likely developed our own techniques of easing patients' anxiety, because that's part of the role that we play, that are, of course, non-pharmacologic. So I try to understand where their anxiety comes from. If it's regarding pain management, which can be, then I educate patients in our pain management strategies. Again, we do expect pain. Please never tell patients not to expect pain, but tell them there will be pain, but we'll make it as tolerable as possible. We have multiple techniques to help with pain management, and I then describe the non-opioid pain medications, the opioid pain medications, as well as I tell patients that it's important that they use non-pharmacologic techniques. Distraction techniques are very powerful. And some patients are going to be anxious no matter what, but we try our best. And that's patient education, I think, is the best way to go about it. If they have questions about the surgery, I'll ask the surgeons to come back to answer the patient's questions.
Thank you. The next question is, are there any good resources or recommendations to give opioid-naive patients information on how to taper their own opioids post-discharge?
The Open Michigan website is fantastic, and they have a lot of great resources, patient education pamphlets that are meant to be given to patients for, again, opioid safe use. So that is one great resource that you can look into. Oftentimes your hospital may have something, but that's one resource you can look into.
Thank you. And the last question we have in the Q&A is, the majority of narcotic addictions and overdose deaths are due to street drugs and not postoperative pain addictions. What percentage of opioid addiction do you ascribe to postoperative pain medications?
That's a great question. And I'm not aware of, I don't know the statistics. What I know, the opioid crisis that started in the late 1990s and early 2000s was largely driven by prescription opioids. Now, it is true that nowadays the opioid crisis has taken a different life, and it is not prescription opioids, but some synthetic opioids, fentanyl, that are very potent, that are being used, that are causing a lot of deaths. But we do know that acute pain and opioid prescriptions during surgery is a risk factor for opioid addiction in the future. And it's perhaps the beginning of the opioid. Perhaps initially, an opioid prescription is what's going to make a patient become addicted and then seek some other ways to get opioids. But yes, I do not have the exact number of which of those patients started their opioid addiction from prescription opioids. I do know that it's still an important gateway to opioid addiction. And, I think a lot of patients really don't have anybody tell them how dangerous opioids are. I will tell you, when I was in the early 2000s, when I got my wisdom teeth extracted, I got some Norco, which is no longer recommended for dental extractions. We no longer recommend opioids for pain management, but Tylenol and NSAIDs. And it was a pretty good get But my friends at that time were telling me, after my wisdom teeth, I got this medication that's, just fun. You should try it. So I had no pain after my surgery, but they told me it was fun. And it was a prescription medication. So I took one pill. Thankfully, it didn't affect me in any way. But I can see how many patients thinking, oh, this is a safe medication, it's a prescription medication, they take it, not realize they're getting addicted. And that may lead to a path of drug addiction. And that's why I think, even in the pre-op area, you might be the only person who tells the patient, just be careful with these medications. And I do understand we don't always have the time. In patient surgeries, it's maybe not as necessary, but I certainly try to educate my patients, patient settings about the dangers of opioids. And a lot of them are more aware nowadays because of the opioid crisis. Because the opioid crisis is more widely known about, basically.
Okay, thank you very much, Dr. Carcamo Cavazos. We really appreciate your time this morning, and you give us your approach and perspective on perioperative pain management. Thank you for the audience for your engagement, and her contact is there if you have any follow-ups. If you're interested in becoming a speaker for Aspire, please email aspirex at stanford.edu. Oh, and if you have a moment, and since we have a few minutes left, one more question just came in. What do you tell patients and parents who are afraid of opioids and that it will cause addiction and they don't want anything for their kid or for themselves? They're going the other side of, on that spectrum.
And I also, this is definitely something that does happen, especially because opioid addiction, opioid overdose has been a lot in the news, that patients are like, I don't want to take any of these medications. I'm scared of them. And I just try to provide education. What I tend to tell them is, opioids are good medications when used appropriately, just for pain after surgery. And sometimes I tell patients, if you're concerned about addiction, involve your family. If you're somebody that is at risk of addiction, you can ask your mom to keep the pills. And if you find you're liking them too much beyond their pain relief properties, tell your family. Most patients don't feel, in my, again, experience, it seems like most patients don't feel that euphoria, but I've had a handful of patients that told me, like, I took one oxy and I liked it too much and it was really scary. So I just educate them that they do have their place. It's a balance of educating them that they should use them just for surgical pain, but they should use them in the lowest effective dose and only for surgical pain. So patient education and assurance, but I do tell patients that opiates do have their role.
Thank you so much. Have a good day, everyone, and appreciate your time here.
Thank you.
Thank you, everyone. Thank you, Dr. Carcamo Cavazos.